We are going to go ahead and just mute everyone while Dr. Chang is speaking. And then we will, there's a chat feature at the bottom of your screen. So if you have questions that you would like to have answered after the presentation, go ahead and use the chat feature to chat those in. And then we'll try and I'll ask Dr. Chang those questions afterward, depending on how much time we have and everything, but we'll see if we can get some of those questions answered. But we are just to reduce the background noise because of the number of people that are here, we're just going to go ahead and mute everybody except for Dr. Chang and let him present.
Okay, great. Well, thanks, Melissa. And my name is Mark McLaren, and I'm very happy to welcome everybody. This is really exciting. A few of us were talking about this for all the things that COVID has made difficult in our world anymore. This opportunity to use technology like Zoom to leverage resources in the ANA and in anything anymore is really exciting. So to have 30 people be here tonight as part of this support group and have an opportunity to listen to Dr. Chang tonight is really exciting. And I'd like to introduce somewhere in your Hollywood Squares thing is Christina Esfanati, which is my co-leader. And we've been doing this, Christine, with Dr. Chang. I was trying to get my about 10, 12 years. How long has it been? Or Dr. Chang?
Yeah. Probably about 12.
12, yeah.
Yeah, that's crazy.
And as I was sharing for the later arrivals, it's been a wonderful opportunity that Christine and I are very appreciative of, that Dr. Chang has been our sponsor for the support group and has really been a tremendous, just not his own time he's dedicated to our efforts, but also tapping into his faculty peers in different disciplines to bring us continually new topics related to acoustic neuromas. So that's been a real gift to us over the years. So with that, give you a little bio, and it's going to be very short on Dr. Chang because I couldn't do a long one or we wouldn't get through the meeting with all the accomplishments in his CV. First and foremost, Dr. Chang is on the ANA Medical Advisory Board. He's also professor and vice chairman of strategic development and innovation at Stanford's Department of Neurosurgery. He's an author and co-author of over 300 peer-reviewed publications at Stanford. As I said, he's been our sponsor for these number of years. And from an AN standpoint, Dr. Chang does both radiosurgery and open surgery. So he is experienced in both. And I think Dr. Chang, last time we talked to you, it was at 50-50 is what you were doing over the years. So with that, Dr. Chang, I'll turn it over to you and let you share your thoughts with us tonight.
Okay, welcome everybody to our support group. And as Mark alluded to, I think it was 2000, might have been 2010, Mark, the beginning of 2010 that we started this. So we're coming up on 11 years. This support group developed out of, as with many of the other support groups at the ANA, developed out of our thought at Stanford to provide education for patients about acoustic neuromas, because it definitely is something where it's a disorder where there's a lot of different potential treatment options, including just watching. And so to navigate the field of the different options can be challenging, and it's also a situation where one size does not fit all. So what is good for, what was the best, maybe the treatment recommendation for your neighbor down the street with an acoustic neuroma may not be the best recommendation for you. With having said that, what I thought I'd like to do today, because I gathered that we were going to likely have a number of people join this support group meeting outside of our normal Palo Alto group. So I thought I'd give a more general topic and then be able to answer questions as they come up. And so the topic that I was going to present tonight is to specifically talk about radiosurgery for acoustic neuromas as the non-invasive alternative to open surgery. And I'm going to cover a little bit of the different radiosurgery machines, but more specifically, I'm going to talk about the Cyberknife because that's the machine that we use at Stanford for acoustic neuromas. So this is a picture of Lars Leksell. Leksell was a neurosurgeon in Stockholm in Sweden, and he actually developed the idea of using focused radiation for the treatment of neurologic disorders way back in 1951. And he published a paper in 1951 about this kind of concept. And at that time, the focused radiation was not designed to treat patients with tumors. It was actually designed to treat patients with tremors and movement disorders. And the focused radiation would zap the area of the brain that was causing the tremor, and the patient's tremor would disappear, for example. Then over time, as neurosurgeons became more familiar with the technology, this was a technology that ultimately became the gamma knife. It started being used to treat other tumors. And by the early 1970s, acoustic neuromas were one of the tumors that he was treating. So when I sometimes hear patients say, well, radiosurgery for acoustic neuromas is a new option compared to surgery. It's not really new. It's been around for 50 years. And the concept of radiosurgery now next year will be the 70th anniversary of kind of the development and publication of the first radiosurgery paper. So again, the concept of radiosurgery developed in 1951. Essentially, what we're trying to do is rather than taking a tumor out with surgery, we're trying to treat a tumor with a focused beam of radiation as a non-invasive alternative. And this is important because not all patients are candidates for surgery. We've gotten a lot better with improved anesthesia and improved surgical techniques over the decades, but even in 2020, not all patients are good candidates for radiation, either because of age or medical comorbidities or some issue that prevents us from getting them through the surgery safely. And so radiosurgery was originally conceived as the non-invasive alternative to that. And as we started seeing the results coming from the radiosurgery treatment being very good, it actually became a standard of care. And I'll show you data at Stanford where the majority of patients that come in with acoustic neuromas are now being treated with this technology. So radiosurgery uses a number of highly focused beams. There are different machines that can achieve this result. I've already mentioned the gamma knife and the Cyberknife, and I'll talk a little bit about some of the other machines. So there are three broad categories of radiosurgery. The first is what's called a LINAC. It's a short for linear accelerator. It's a machine that delivers very focused X-ray beams of radiation. This was kind of the earliest form of radiation developed, and it's the most widely used form of radiation today. The Cyberknife is a type of linear accelerator. It's a much more robotic design one than this one that you see in the upper left corner there. But the first type of radiosurgery is a linear accelerator. At the bottom, we talk about the gamma knife. The gamma knife was the machine invented by Dr. Leksell. It uses radioactive cobalt as the source of radiation to deliver the radiation to the tumor. And then in the middle of the screen, there's protons, which are heavy particles, which can be used for certain types of tumors. It's not commonly used for acoustic neuromas compared to linear accelerators or gamma knife radiosurgery. So this is a picture of the Cyberknife, and in the picture there's several different components that I like to talk about when talking about the Cyberknife. The first is this lightweight linear accelerator. You'll see toward the middle of the screen here a kind of a rectangular box. That box is the entire linear accelerator. So it's the source of the radiation comes out of that small box. Prior linear accelerators were very large, weighed 2 tons, and there's no way you could shrink them down and use them in this type of situation. The second thing you'll see is this robot. There's this robotic arm there, and it moves the the linear accelerator or the source of the radiation around the patient. This is the same type of robot that you'll often see on the automobile assembly lines, moving around, putting parts onto cars. So it's a high precision robot, and it can point the linear accelerator with less than 1 millimeter of error. There are image detectors you'll see at the floor here. And what these image detectors do is, using the X-ray sources at the ceiling that are shown and with the arrows up here, we are able to track the patient motion in real time. So during the treatment, if the patient were to wiggle a bit or move a little bit, all that motion is detected for and compensated for by the Cyberknife. And that's how we're able to deliver the radiation accurately. This is kind of the newest generation of a Cyberknife. It's called the M6. It's the latest generation that's currently out. There is a newer generation called the S7, the 7th generation Cyberknife, that is just been released and hasn't been installed anywhere in the world yet. So this is the current existing generation of the Cyberknife, and you can see it looks high tech, it looks robotic. You can see there's even some mood lighting at the bottom of the machine of green. And that was done as a patient focus group where they showed all these different colors to patients. And it turned out that this light green light made patients feel the most relaxed. So they incorporated that light into the Cyberknife so that during the treatment, the patient would feel the most comfortable. And again, here's another picture of the most modern type of Cyberknife treatment. So let's talk about the advantages that radiosurgery has over surgery, and then the disadvantages. So the primary advantage of radiosurgery, and I think why most people pick this treatment, is that it's an outpatient, non-invasive procedure. Conceptually, surgery is very, very safe, but an acoustic neuroma surgery usually takes somewhere between 8 to 12 hours on average to do. And so that's a kind of a daunting time period for patients to feel like they need to remain under anesthesia. The other issue that some patients have is the concept of opening up the skull. Patients, when you operate in different parts of the body, there are certain body parts that are kind of maybe more specialized or more kind of concerning. And when you start talking about opening up the skull and operating on the brain, it's a much different category than having knee surgery or abdominal surgery. So the main advantage of radiosurgery, it gets the patient out of the operating room. You're treated in street clothes. You jump on the table, you get treatment, jump off the table, jump back in your car. There's none of the surgical risks. So you don't have infection or bleeding or anesthesia issues or spinal fluid leak. And there's no recovery period. Patients literally can go from their Cyberknife treatment back to work. I like to tell a story of one of my patients who was a gardener and was planting flowers around the Stanford campus. And at the time of treatment, we called the patient up. They stopped what they were doing. They literally left their flower pots out on the sidewalk, walked in to get their Cyberknife treatment. And then after they finished their Cyberknife treatment, went right back to planting the flowers. So they just picked up right where they left off. The radiosurgery does have some disadvantages. And I think it's important to understand what these disadvantages are, because the disadvantages need to be factored into the decision of timing of treatment. So the primary disadvantage of radiosurgery is that it takes 2 to 3 years for us to say that the tumor is fully died from the radiation treatment. Why does it take so long? It's a tumor, shouldn't it die pretty quickly? It turns out that malignant cancerous tumors, when you radiate them, will die very quickly, but benign, slow-growing tumors die very slowly. So the faster a tumor grows, the faster it will die from the radiation, and the slower a tumor grows, the slower it dies from radiation. And I always tell patients, like, you don't want a tumor that dies quickly after radiation, because that's usually a bad tumor. You want a tumor that's just going to stop growing. We call it tumor control. It's not going to get bigger in your lifetime, and we're going to have a high success rate. A second disadvantage of the radiosurgery is that as the tumor dies, there can be some inflammation that goes on, and the inflammation is a direct result of the radiation killing the tumor. So as you have this inflammation, a patient's symptoms can fluctuate during the first several years of the dying process. And so you could be a situation, you're 1 year or 2 years out from your radiation treatment, the scans look good, the tumor looks good, but the patient can say, I've had a couple of flare-ups of my tinnitus over the last 6 months. And that's all part of the process here. And because it can be very delayed, because it can be 1 to 2 years after the radiation, patients don't necessarily always remember that there was a conversation at the time of treatment that this is a potential expectation. Sometimes we'll get a call from a patient several years after treatment saying, hey, this is going on or that's going on. And we just basically remind the patient that this is part of the dying process of the tumor. And it means that the patient's tumor is actually responding to the treatment. A third disadvantage, which is actually, I don't consider a very large disadvantage, is that no pathology is established. And what does pathology mean? It means a piece of the tumor is given to a pathologist who is a physician who will study the tumor under a microscope and confirm that it is indeed an acoustic neuroma and not some other type of tumor. The reason why for acoustic neuromas this is not very critical is that acoustic neuromas have a very classic appearance and location. And when you look at a scan and you see an acoustic neuroma, it's very unlikely that it's going to be something other than an acoustic neuroma. So, but it is true that if you do radiosurgery, you're foregoing your pathology report. And last, the radiosurgery cannot be used for large tumors. And this is because a large tumor is usually causing problems from pressure on the brain, or what we call mass effect in neurosurgery circles. And radiation, if you remember, it just stops the tumor from growing. It doesn't necessarily shrink the tumor a lot. So if you have a large tumor and it's pushing on your brain and you're having problems, you're falling over, you're having face pain or some other symptom related to pressure, the radiosurgery is not going to be a good option for that. Now, the reason why I talk about timing here is that I see some patients and they have a small to medium sized acoustic neuroma and they're debating whether to do radiosurgery or not. And a lot of times a common comment I hear is, well, I'll wait for my tumor, and if it grows and gets bigger, or if I develop some symptoms, then I'll come in and get the radiosurgery treatment. And the thing to keep in mind is, because it takes 2 to 3 years for the tumor to respond to treatment, if you wait till your symptoms are more severe, we may not be able to reverse those symptoms. And furthermore, if you wait until your tumor grows, you may lose the window by which we can treat these tumors, because remember, large tumors cannot be treated safely with radiosurgery. So there are some situations where patients have a tumor, it's within the size criteria for radiosurgery, but they opt to watch, and sometimes they watch over a number of years, and over time the tumor gradually grows and grows and grows, and at some point it becomes too large for radiosurgery, and so now that option is off the table. So you have to kind of think a little bit longer term when it comes to dealing with the disadvantages of radiosurgery, because not all of them come into play right off the bat. So I thought I would just talk a little bit about the steps of the radiosurgery treatment. Like what do you expect to go on in terms of the timeline? The first is a consultation by both a surgeon and a radiation oncologist. And this is because radiosurgery in the United States is a multidisciplinary team approach. You have a neurosurgeon and you have a radiation oncologist, and then you have a bunch of behind the scenes medical physicists that do all the calculations of the radiation beams. But generally, you'll see the surgeon and the radiation oncologist in their clinic. Some may be at the same time. They may see you together, or they may see you in different times. But ultimately, what you want to do is get the consultation by both of these specialists. They'll determine the suitability of treatment. What's the probability of the tumor dying from the radiosurgery, and that varies based on size. And I have some slides later on in the talk that will cover that. If you decide to proceed with treatment, the next step is called the simulation or the preparation. And this involves coming into the medical facility to get some special pictures, thin slice MRI scans, thin slice CT scans, and then you go home. And then after you go, while you're at home, the neurosurgeon and the radiation oncologist and the medical physicist will create a treatment plan, a series of radiation plans that show the different beams coming in from many different angles to target the tumor. And this plan is reviewed by both the neurosurgeon and the radiation oncologist and signed off. And then the patient is then scheduled for the treatment. In a typical gamma knife, all this can happen in the same, steps 3 and 4 will happen typically on the same day. In a Cyberknife treatment, 3 and 4 can happen at the same day, or they can happen on different days. And then lastly, follow-up imaging and clinic visits are necessary to monitor the response to the treatment. So I wanted to talk about how radiosurgery has evolved over the years. So as I mentioned, it was being done in Europe for acoustic neuromas in the 1970s, in the early 70s. And by the mid to late 1980s, radiosurgery was brought over to the United States and being done here in the US. For the first 5 to 7 years of radiosurgery for acoustic neuromas, we were using much higher doses than we currently use at the present. And this, you'll see in this chart here in the upper horizontal line shows 87 to 92. This is gamma knife data where we were using doses about 50% higher than today's dose. We're getting really excellent tumor control, 98% success rates, but you can see hearing preservation was only 50%. And because the doses were higher than we use at the present time, we were starting to see some irritation of some of the other nerves. So the facial nerve and the trigeminal nerve were being impacted. So what we learned is that you can lower the doses. By 1991, we were down to kind of lower doses, what we use at the present time. And we were still being able to maintain 98% tumor control. But you can see the impact on the other nerves, particularly the facial nerve and the trigeminal nerve, came down dramatically. And you can see hearing preservation started going up. So what we also, and this data in this table this is for single session radiosurgery done by the gamma knife. So you come in, you get one treatment, and that's it. We were at Stanford in the mid 1990s. We were looking at some of this data, and we said, well, you're really good at the tumor control. You're really good at preventing problems now in the face nerve and the trigeminal nerve, 1% chance. But the hearing is only 70% chance of keeping hearing, and this is over the first 3 to 4 years. So what can we do to improve that? And so we started breaking up the radiation dose into 3 sessions. So rather than one shot of radiation on a Monday, you would get a third of the dose on Monday, a third of the dose on Tuesday, and a third of the dose on Wednesday. And our thought process there is that would be gentler on the hearing nerve, and that would give us a better chance of hearing preservation. So this is some data. This is what's called a meta-analysis, and essentially what this is combing through the neurosurgery literature and the radiation oncology literature and collecting all the publications that look at hearing preservation for acoustic neuromas. And in the top bar there under hearing, you see for N, that's the number of patients. There are 4,234 patients that were reported in the literature at the time that this paper was published. And you can see that they basically arbitrarily picked a dose of 13 gray. Gray is a measure of radiation units, and said, what was the hearing preservation rate for patients that received 13 or less gray versus those that received 13 or more gray? And you can see that those that received less radiation had better hearing results. And you can see the same for the facial nerve and for the trigeminal nerve. So again, this slide just shows what I showed in the last slide, which is we've gotten better over the decades at optimizing the dose of radiation, both to kill the tumor, but to minimize any side effects. So let me go. Yeah, I want to go talk about this slide. So at Stanford, we started doing radiosurgery in 1989. And from 1989 to 1999, we used a frame-based linear accelerator system similar to the Gamma Knife. And then from 1999 to the present, we've been using the Cyberknife. For patients that come in with good hearing or reasonable hearing, we've been doing 3 treatments for the reasons that I just outlined: hearing preservation, maybe higher. One of the differences between our center and many centers that treat acoustic neuromas is that we tend to be able to, or we tend to be willing to treat larger tumors than other centers. So some of the tumors I see, there are maybe 2.5 centimeters, 3 centimeters. The patients are told at other centers, well, this is too big for radiosurgery, you need to have surgery. But then when we take a look at the film, based on our experience, this is something that's treatable. This slide, I think, is pretty interesting because this is our data at Stanford, and it shows over the years how the treatment has for radiosurgery for acoustic neuromas has evolved. So you can see around 2000, 75% of patients with acoustic neuromas that came into Stanford were being treated with surgery, and only kind of 15 to 20% were treated with radiation. But you can see that within a short period of time, radiosurgery with the Cyberknife started becoming more and more dominant. By kind of 2004, 2005, half the patients that were being evaluated at Stanford were treated with radiosurgery. And then you can see by 2014 to 2018, it's almost 70% of patients that have acoustic neuromas at Stanford are treated with radiosurgery, and only 25% are treated with open surgery in the operating room. This is a typical treatment plan for an acoustic neuroma. And you see on the right side, here's the tumor. It's outlined. These color lines actually are kind of a ripples in the pond type of halo effect of the radiation treatment plan. So the green line is the kind of dose of radiation that we want to give to the tumor. And you see it kind of really follows the red tumor outline. And then the light blue and the dark blue lines are successively lower radiation doses. On the left side, this is a little image of the patient's head, and each of these little lines is a different beam of radiation coming in from different angles. So you can see that using the Cyberknife, we use about 100 different beams of radiation to treat the tumor. So in terms of kind of what's the expectation if you get radiosurgery for your tumor, this is our data at Stanford. That was published, I think now about 7 or 8 years ago, but it's still pretty much the present and current data. So you can see over time in years on the horizontal axis and tumor control in the vertical axis there. So our 5-year control rate is 96%. 3-year control is 99%. So you're still getting pretty good results there. We actually decided to break this down by size. So for tumors that are small, small to medium sized tumors, so this is defined as less than 3.4 cubic centimeters, the control rate's like 98%. So which is very, very good if you have a small to medium sized tumor. For larger tumors, it's not as good. So this is, you see, if you come in with a small to medium sized acoustic neuroma, we have a 98% chance of killing the tumor. If you come in with a bigger tumor, like 3 centimeters, you're down around 89 to 90% chance of tumor control. So this is one of the things that you need to keep in mind. If you have a smaller tumor and you're watching it, this is a factor that you should consider, because as your tumor grows, even if you then come in for radiation treatment, you're going to be following the red line, not the blue line, if you wait for the tumor to get too large. So in terms of kind of other side effects, facial weakness, the facial nerve is the nerve that controls movement in the face. In our series of patients that we published in the same paper, we had 0% had any facial weakness. You can see a few patients have twitching in the face or some face, some tingling in the face. Most of these are temporary in nature. This slide here gets a little bit more technical and talking about the Coues classification, which essentially is just size. And the take-home message from this slide is that the smaller tumors have better control rates with radiation than the larger tumors. So if you come in with a larger tumor, you're going to not have the same success rates as you would with a smaller tumor. So small tumors, 96%, larger tumors, 90% chance of killing the tumor. This is a slide that I put together looking at the published papers that had 100 or more patients in it. And I think really the take-home message here is that everybody's using about the same dose and everybody's getting about the same kill rates on the tumors, about 96% kill rate. This is a slide that I use to talk about the instances where we will combine surgery and radiation. So on the far left, you'll see the patient's original tumor. This patient had a large tumor. You can see it's pushing on the brain. They were having some balance disorders, and clearly it needed to come out. But the patient was kind of adamant about avoiding any chance of any facial weakness, which we know is one of the known risks of open surgery. And so we did kind of a hybrid strategy here, is that we did a surgical debulking of the tumor and removed about 90% of the tumor. And you see the middle slide here this is the remaining tumor after the surgery. So we took out 90% of the tumor. This is a tumor that's left along the facial nerve. And then we treated this with the Cyberknife. And now the patient's over 5 years out, and you can see that the remaining tumor died and hasn't changed in size since the Cyberknife treatment. So you can combine the surgery and the radiosurgery. It's not necessarily an either or situation. This is a slide that I put in. It goes way back, but it shows a phenomenon that we still observe to this day, is that when a tumor as a tumor undergoes the dying process after radiation, it can temporarily swell. It's no different than if you sprain your ankle, it could, the next day when you get up, it could be more swollen than the day you actually sprained it. The time course of swelling after radiation for acoustic neuromas is usually anywhere between 6 to 18 months after treatment. And so it doesn't occur right away. It occurs in a delayed fashion. And so you just need to be aware of this, so that if you see something like this as a physician, you don't tell the patient, hey, your tumor's growing, we need to do surgery. Because not in the vast majority of these patients that swell, the tumor shrinks back down over time. You can see this phenomenon there. So kind of to summarize, and then I'll take some questions. The radiosurgery has been used now we're going on 5 decades for acoustic neuromas. So it's technically not a really brand new technology. It's established treatment with lots of data. The dosing and fractions have evolved over time, but there really hasn't, in the last 10 years, there hasn't been any real change in the dosing and fraction. We think we're at the lowest dose we can do right now and still keep the tumor success rates to be very high. Radiosurgery is non-invasive compared to surgery, but it takes several years to show that you have tumor control. And the overall tumor control rate, as I shown, is very good. So that's kind of my broad overview. I'm going to stop now and be happy to open it up to questions at this point. And I'm going to switch back to my Zoom meeting so I can see the chat.
There you go. Okay. If you want to go through the chat, you can, you're certainly welcome to do that and take questions, or I can ask you so that everybody can hear them.
Yeah,
I'm happy to do that too. Okay. So the first question we got was, does radiosurgery make future acoustic neuroma surgery, if needed, more complicated? This person is saying they've heard that the tumor becomes more sticky.
That's a good question. And so there's a couple comments on that question. So theoretically, that question is kind of the half of the question. Because the broader real question should be, does a previous treatment for an acoustic neuroma make a subsequent treatment more complicated?
Mm-hmm.
Because some patients will have one surgery and then 10 years later have a second surgery. There's no radiation involved in that. Some patients will have radiosurgery, and then if they're in the 5% where the tumor grows, they would have a second radiosurgery. Again, there's no surgery in that either. So what we know in medicine is that the first time you do a procedure, everything is normal. When I mean normal, it's the anatomy is normal. There's no scar tissue. The tissue planes are where they're supposed to be. When you do a second procedure, there can be some scar tissue. There can be some adhesions. There might be a hole where the surgery was done to remove the tumor. The brain may not have filled in the complete space. So the anatomy may not be completely normal. So I like to tell patients that any prior treatment can make a second treatment more challenging. It's not always the case. Sometimes it makes no difference at all. Like in the case of if a patient had prior radiation and that subsequently needed to have surgery, on one hand, the tumor might be a little bit more sticky, but on the other hand, the radiation often reduces the blood supply to the tumor, and it makes the tumor much less bloody during the surgery, which then makes it actually easier for the surgeon. So and these two factors can almost offset. If it's 25% more difficult because there's some scar tissue, but it's 25% easier because there's less bleeding, it almost kind of washes out. And so I've done surgery after, I've done open surgery after acoustic neuroma radiosurgery, and I've not found it to be too much more different. I wouldn't say it's like twice as difficult or anything like that. If anything, it's maybe, 10 to 20%, maybe a little bit more difficult, but not double or anything like that. And there's some cases that we've done open surgery after radiosurgery where I would say there's pretty much absolutely no difference at all.
Mm-hmm.
So this, and again, this is case by case, patient by patient basis.
Yep, that makes sense. This question is about vestibular function after Cyberknife. We've had this question a lot at the Acoustic Neuroma Association as well, and just what to expect as far as vestibular function after Cyberknife treatment.
That's actually a very good question. And I actually like this question because it's one of the things, one of the symptoms that we have some good options for compared to like tinnitus, for example. With vestibular function is essentially your balance. And we know that the acoustic neuromas are actually more correctly called vestibular schwannomas because they're tumors on the balance nerve. They're not a tumor on the hearing nerve. So the acoustic neuroma is a misnomer, but it's kind of what people have been calling it for decades. So let's call these now vestibular schwannomas. They grow off the balance nerve. So if you were to treat the tumor or even not treat the tumor, just the fact that you have a tumor on your balance nerve may make you have some balance problems. But the balance nerve is not the only component of balance. It's also your vision, and it's also what we call position sense, where your arms and legs are in space. And I'll give you a couple of different examples. For example, if it's dark, if you get up in the middle of the night and it's dark, you're gonna feel your balance is not as good. You're gonna be walking more tentatively. Why is that? There's nothing wrong with your vestibular nerve. It's your vision. Your input from your eyes is not going to your balance center, giving the reinforcement. Likewise, if you sit funny on the couch and you wake up and your legs fall in asleep and you start walking, you're gonna be wobbly, your leg's gonna be tingly. You're gonna have balance issues there. And then again, that's also not because of anything wrong with your balance nerve. It's because your leg is not telling your brain where it is in space. And so vestibular issues after either surgery or after radiation treatment, or even after patients that are in the watch and wait mode, you can work to build up those functions with what's called vestibular therapy or balance therapy. So again, you have the three components of balance: your balance nerve, your vision, and your joint position sense, and vestibular therapy builds up all of those. So in general, if you are having acute balance problems, that's typically what we prescribe. In the long run, if you look at data that's on the Acoustic Neuroma Association webpage, the patient surveys that look at self-reported balancing, it seems to get better after radiation. down the line. And when we're talking about long run, so 4 or 5 years out, patients report their balance function was actually better than it was before radiation. They also report balance function improving after surgery too. So some of it, I think, maybe just the patients are adapting, and some of it may be that they're using this vestibular therapy.
Gotcha. Okay. And there's a question about multifractional versus single session treatment. It's asked specifically about whether or not Stanford has collaborated with the Kaiser group in Redwood City, but ultimately the question is, what are your thoughts on multifractional versus single session treatment?
That's a good question, because the multi-fraction treatment actually, does take more time. The patient has to come in, like in our institution, 3 days versus 1 day. So if you live close to Stanford, that may not be that big a deal. If you live farther away, or you're flying in from out of state for treatment at Stanford, you're going to have to spend a few extra days here. So there's an investment of time up front when you do the multi-fraction treatments. The advantage of the multi-fraction treatment is it's thought to give the patient the best chance of hearing preservation. And the reason why I use the word thought to is that there has been not to my knowledge any direct true scientific study on this, because a scientific study would involve the physicians randomizing patients to either 3 sessions of radiation or 1 session of radiation, and thereby taking the decision away from the patient. And I think it's a challenge in this day and age to run that kind of study where we would take 100 patients and tell them, we're going to flip a coin, and half of you are going to get 3 treatments and half of you are going to get 1 treatment, and you guys don't have a choice. That typically doesn't go over well with patients. And patients like to be involved with their decision. We encourage them to be involved in the decision, not just with this, but with the surgery versus the radiation treatment. So we think that as long as the patient has good hearing, then we offer them the multi-fraction treatment. The vast majority of patients that we offer it to do think it's worth that extra couple of days. So the majority of patients do the multi-fraction treatment if they have good hearing.
Okay. And to continue on with symptoms following Cyberknife, if you go into Cyberknife and you are asymptomatic, can you expect to remain that way, or what can you expect after that treatment?
If you go into the Cyberknife and so generally the best predictor of what symptoms you're going to have after Cyberknife treatment is what symptoms you have coming in. So if a patient shows up with very minimal symptoms, like maybe a little bit of tinnitus, and that's it, that's they have good hearing, they have good balance, the likelihood of them coming out, 3 years later, having the tumor being completely killed with the radiation and having no additional symptoms is quite high. If you have hearing loss and you have balance issues and you have tinnitus, then we can't necessarily undo those symptoms. At that point, I like to tell patients, look, that's your baseline. Whatever your baseline is coming in terms of your current symptoms, we will try to kill your tumor. We have a good chance of killing your tumor. Other than the hearing, which we talked about, we're trying to preserve, the other symptoms typically don't change much from what you already have coming in, but we can't necessarily reverse symptoms that you had. So, when sometimes a patient will say, I have great hearing and great balance and great everything, and I'm going to wait till my balance is bad, and then I'm going to come in and get radiation treatment. And that's fine. We can do that, but that is your new baseline when you show up for treatment. If you wait till you have balance problems and then come in, I'm going to basically tell you what you have coming in is what you're going to probably have coming out. That's the best predictor. Having said that, patients can improve in symptoms. Patients can have improvement in balance. They can have improvement in some of the other symptoms, including we've had a small subset of patients, about 4 or 5% have improvement in hearing. So you can have improvement, but it's less than 50% show improvement, and more than 50% just show stability of their symptoms.
Okay. And how about Cyberknife versus Gamma Knife as far as outcomes, as far as advantages and disadvantages of one over the other? What are your thoughts there?
Okay, that's a good question. So Cyberknife versus the Gamma Knife, the differences are source of radiation, which is not necessarily relevant because the tumor doesn't know where the radiation came from. It just sees a certain dose of radiation. The acoustic neuroma will not know whether it's a Gamma Knife or Cyberknife. It just sees, I see a dose of radiation. So in terms of accuracy and tumor kill, probably there's no difference between the two machines. Many Gamma Knife centers still use the frame-based system where they have to attach a frame to your head. That usually restricts the radiation to a single shot because you have a metal frame attached to your skull. The Cyberknife does give a little bit more flexibility if you're going to do multiple treatments for the tumor. But in terms of accuracy, no difference. And in terms of tumor kill, no difference.
Okay. And with any type of radiation, patients are dealing with follow-up MRIs for whatever time is recommended by their doctors. So what is your recommendation there for, this patient is 7 years post SRS treatment, and do you recommend the gadolinium contrast dye or not using the dye for follow-up?
So this is a timely question because it's come up more and more recently due to a concern of the gadolinium being given to patients. There's some anecdotal reports. So gadolinium is an element on the periodic table, if everybody remembers back to high school chemistry class. So it's considered a metal, so it's like zinc and copper. And so when they give you the gadolinium, essentially they're flushing this element in the periodic table into you. And so some of you that have had the gadolinium might have experienced a funny smell or warm sensation. That's some of the chemicals, but the question is, does this metal stick around in your body? Like if you kept flushing me with copper, would some copper stick around my brain? So the answer to that is there is some data that shows that on the cellular level, there's some gadolinium that sticks around in the tissue. It's not clear whether or not this means anything because gadolinium has been used for now about 35 years. It seems to be safe. And there's lots of patients that, for example, that have cancerous tumors that get MRIs very frequently, like every 3 months with gadolinium for years and years and years. Having said that, we try to be judicious about the use of gadolinium. So whenever you get an MRI scan, they'll also do non-contrast images. And if we can see your tumor very well in the non-contrast images and the gadolinium is not adding much, then we will tell the patient, hey, on your next follow-up scan, we can do a non-contrast MRI scan because we can see the tumor size and shape clearly. So typically we like to get at least 1 or 2 scans with gadolinium to document the tumor size and shape. But after that, we've been switching to non-contrast scans going forward, as long as we feel like we can visualize the tumor.
Yep, that makes sense. Okay. And what, if any, are the other factors that are associated with outcomes besides tumor size? And is there a size that is too small for treatment? This patient has a tumor that's 5 millimeters.
That's a good question. Factors associated with health outcomes. I'm not sure what health outcomes mean, so I'm going to answer this a couple different ways. Okay. If you're talking about, minimizing side effects or something like preserving hearing, we do suspect that possibly, considering earlier treatment may be better than later treatment. There was one paper out of University of Pittsburgh that showed that those patients with acoustic neuromas that were treated within 2 years of diagnosis had a better chance of long-term hearing preservation than those treated more than 2 years from diagnosis. So possible time is a factor there. Other than that, we talked about the size. We talked about symptoms coming in. So somebody with 5 millimeter tumor could have 0 hearing in that ear, or they could have perfect hearing. So there's still some variation. Size doesn't necessarily correlate with severity of symptoms. In terms of size for treatment, 5 millimeters is quite small. So many times, certainly a watch and wait option is a good choice for that. Having said that, the 5 millimeter tumors have extremely high control rate after radiation, the 98 to 99%. Tumors that are small, if anything, have a better chance potentially of hearing preservation than larger tumors. And again, small tumors generally, the patients don't typically have a lot of symptoms. And so if you follow the guideline of less symptoms gives you, a better outcome, then it might argue to consider potential treatment. But having said that, 5 millimeters is quite small. I would probably say, especially if the patient's had several scans that have showed no change in size, it certainly would be reasonable to consider following that in the short run.
Okay. And this is a topic that comes up, a lot when we talk about radiation. You mentioned it a little bit, but what are the chances of getting cancer from radiation to treat an acoustic neuroma?
Yeah, I like this question because you're right, it comes up a lot. And so I try to use some kind of examples to put this in perspective. So, the thought of getting cancer from radiation treatment is very, very low, and it's low enough that the exact probability is hard to calculate. So most people will use numbers somewhere between 1 in 2,000 to 1 in 100,000 in the patient's lifetime. With probably the majority of people quoting maybe 1 in 10,000 to 1 in 20,000 in the patient's lifetime. So the reason why I say we want to put that in perspective is that you have, let's say we pick 1 in 10,000 as a number. The men on this support group, we have a 1 in 10 chance of prostate cancer in our lifetime, and women, let's say you have a 1 in 10 chance of breast cancer. So I do have people that worry about this probability of cancer from the radiosurgery, but they're not getting their prostate checked, or they're not getting their mammograms checked.
Right.
And so you sort of wonder, you're worrying about a very, very low probability, but you're ignoring a greater threat to your health. Couple other probabilities to factor in there. The chance of dying from open surgery for acoustic neuroma is about 1 in 500. So let's say we take this 1 in 10,000 chance of getting cancer. That's in your lifetime. So that's 20 years down the line. You have a 1 in 10,000 chance of maybe this happening versus a 1 in 500 chance of potentially not surviving the first week after surgery if you have open surgery. So I do get some people that say, I'm worried about the cancer from radiation, so therefore I'm going to pick surgery. Right. And I think you essentially are moving from a lower probability risk to a higher probability risk when you make that decision.
Sure.
So I think the bottom line is I think it's quite low. I don't even use that as a factor in determining treatment options because I think it's so rare.
Yeah. Yep. Okay. That's good. And then when you are dealing, you talked about the way that the tumors can potentially swell after treatment. Do you use steroids to treat that inflammation when it occurs?
So if the tumor swells and causes some symptoms, but the symptoms are mild and it's manageable for the patient, and everybody understands that this is the process of the tumor dying, then we typically just kind of use positive reinforcement to the patient. We just kind of remind them this is a process that can happen. If it's mild, we want to just kind of ride it out, but let us know about any changes. If the symptoms are more pronounced, like they have abrupt hearing loss, or their balance is suddenly worse, then we will treat the patients with a pulse of steroids, usually for a week or two. The steroids are strong anti-inflammatory medications, and the thought process is that the symptoms are from the inflammation from the radiation, and if we could somehow slow down the inflammation or reduce the inflammation, the symptoms will get better.
Okay. And for a while there was there were articles coming out talking about low dose aspirin and its effects on potentially slowing the growth of acoustic neuroma or helping with that. What are your thoughts on that?
That's a good question, and you're correct that this question comes up a lot. Less now than a couple years ago, but still comes up. So there was a paper that came out probably about, I think maybe like 5 or 6 years ago now, that was a study that showed that patients that were taking aspirin and had an acoustic neuroma appeared to have a lower rate of tumor progression than the patients that were not taking aspirin. And I can't remember exactly why the patients were on aspirin. I don't know if it's specifically to try to stop the acoustic neuroma or whether it's not, but that created a little bit of excitement because maybe I can just take an aspirin every day and then my acoustic neuroma tumor would not grow. The problem is that there have been attempts to repeat this study, and the attempts to repeat this study have not shown the same results that I'm aware of. That meaning that aspirin didn't appear to change the growth rate of acoustic neuroma. So this is kind of, so I think maybe some of this questions on this have died down, maybe because of that. But my thought is that it probably doesn't necessarily change anything. But you know, there's a lot of other reasons to take aspirin for heart protection and stroke protection. So you're probably going to benefit more for taking it for those reasons than for stopping your tumor from growing.
Exactly. Okay. And we have a couple more. I'll do a couple more. We're getting to be about an hour here, so I want to be respectful of your time. But there's a question about Cyberknife, and does it have any effect on the vestibular nerve, similar to the way it might be affected during surgery?
Okay. So with surgery, to get the tumor out, you actually have to cut one of the two vestibular nerves you have two on each side, two on the right and two on the left. Usually to get the tumor out completely, you have to cut the nerve because the nerve goes into the tumor. When you treat the tumor with Cyberknife, you are obviously exposing the vestibular nerve to the radiation treatment, but generally it doesn't destroy the nerve per se. If you still studied the nerve later on, you would see live nerve cells running through it. But oftentimes the impact on the nerve, if you particularly have a large tumor, the tumor may have already destroyed the nerve or impacted the nerve even before you get to the treatment. So a lot of times this is not too relevant. And in terms of why patients improve potentially after treatment in terms of their balance, it may be because you're taking an injured nerve and either removing it or killing the tumor so there's no more inflammation. But it doesn't destroy the nerve with the radiation, but it may already be functionally impacted by the tumor.
Okay. And this question is from a patient who's obviously dealing with tinnitus and asking, does it ever go away? Is there any effect that that Cyberknife or radiation has on tinnitus, or does that kind of follow the same line that what you come in with sort of is what you go out with?
Tinnitus is a challenge, and if you remember back to the question on vestibular function, I mentioned that that's something we have a good treatment for. Tinnitus, we don't have a good treatment for, and part of the issue is tinnitus is a perceptive problem up in the higher part of the brain. So the true definition of tinnitus is the perception of sound in absence of any real sound. So there is no real sound, but your brain is being tricked into thinking that there's sound. And it's almost like an auditory hallucination in that sense. It's being tricked. And so because tinnitus is essentially a tricking of the brain, it's difficult to manage. Like I have a couple of other kind of examples that I use with tinnitus. One is, phantom limb pain is a type of syndrome where a soldier might lose their arm and they'll tell you their hand hurts, but they clearly don't have the hand. But the brain is being tricked into getting signals from that part of the body into thinking that the hand is still there and that it's hurting. Or if somebody comes to you and says, I think I just saw a ghost. The problem is not necessarily with their eye. The eye is just translating images to the brain. It's the perception of the brain and creating that image into a ghost. So tinnitus is a kind of an auditory hallucination in the brain. It's difficult to manage. Some patients report it gets better. I've often wondered if it's just adapting to it. I can say that one thing that does make tinnitus be at least perceived better is whether it's fluctuating or not. So when tinnitus is, if it's constant and doesn't ever change, it's easy to ignore. When it moves up and down and fluctuates, it's hard to ignore. So when you ride on an airplane and the sound is very loud in decibels, it doesn't bother you because it's constant. But when you go outside and you hear a fire engine siren where it goes up and down, you can hear it blocks away because of the fluctuation in the sound. And so if tinnitus is fluctuating, it bothers patients a lot. If it's there but doesn't fluctuate, it bothers the patients less, but it typically doesn't go away.
Okay. All right, let's take one last question. This patient is asking if it's true that 50% of patients do not experience tumor growth after the initial discovery of the tumor, I guess for ones that are observed. And after that initial diagnosis, is it true that half of them do not experience growth?
Yeah, I think that might be a little bit of an overgeneralization. I think discovering smaller acoustic neuromas in older patients are less likely to grow than discovering a tumor in a younger patient. And I don't think we fully understand which ones don't show progression over a long period of time versus which ones do show progression. So I don't know if I would say it's 50% because this also assumes over what time period. Is it 50% over 5 years? Is it 50% over 20 years? And I think if you're talking about decades, I think this number is way too high. I think if you're talking about decades, it's going to be most tumors will grow, most acoustic neuromas will grow. So I don't think that that's an issue. I just want to clarify one thing because I know it came up in the questions. So the Cyberknife is a form of stereotactic radiosurgery. So stereotactic radiosurgery is a generic name for gamma knife, Cyberknife. They're all under the umbrella of stereotactic radiosurgery.
Okay, that's great. I'm gonna unmute Mark and Christina. Where'd she go?
I'm here.
Oh, there we go. And let you guys just kind of close things up.
Okay, and first of all, thank you, Dr. Chang. That was a terrific presentation, and just looking at everybody's questions, I think a lot of great questions, and they really covered the full range of what I've heard over the years that people ask about it. So I think it was you laid out a very comprehensive discussion of the topic, and I think everybody had a good opportunity to kind of clarify things. So thank you for doing that. And I think up to you too, Christina. But I'm happy to stay on for a little while, and we can have some open discussion for folks as well. And excuse Dr. Chang, and again thank him for his time. So Christina, what do you think?
Yeah, that's fine with me.
Okay, so anybody who would like to stay, we can do that. Melissa, I don't know what timeline you want to put on that, but we can do that for a while, and anyone else can get on with the evening, I guess, or
that's completely
depending where you are.
I'll stop recording because the presentation and the Q&A is over, so I'll stop that part of it.